Good morning, Emeritus Chairperson sir, VC sir, Principal sir, MS sir, and dignitaries, my fellow colleagues and dear students. Today's topic of 17th PGCR is an approach to painful joint. And as we all know that painful joint is one of the most common symptoms presenting to any of the OPD, varying from medicine, surgery, orthopedics, PNR. So it's a very important symptom. So we have requested Department of Orthopedics to make a PGCR on approach to painful joint. So today's PGCR is being moderated by Dr. Karthik from the Department of Orthopedics, and the chairperson are Dr. Sandeep Yadav and Dr. Anand Sharma. So let me break the ice by saying that not all the joint pains are arthritis. Some are manifestations of systemic diseases, or joint pains may have some systemic implications as extra-articular manifestations. So not all the joint pains are arthritis. We need to work them up. And there are certain foods like turmeric, ginger, green leafy vegetables. They can help in arthritis. As we can see in the graph on the left side, that over the last 3 decades, this osteoarthritis has almost tripled in India. There is a role of stress and joint pain in this presentation of arthritis. And contrary to common belief that whenever the pain is there in joint, you should take rest. There are many arthritis in which if you can strengthen the muscles, these pains can get better. So now I will call Dr. Karthik to proceed further.
Thank you, sir. My name is Dr. Karthik. We have gathered here to have a discussion on approach to clinical joint. I'll be talking about introduction and epidemiology, and later on case discussions. Dr. Akshay will be discussing about types of joint and their classification. Dr. Mohit will be talking about the clinical approach, having history in the examination. Dr. Nirmay from medicine will be talking about the system examination, the extra-articular manifestation and blood investigation. And in the end, Dr. Rukaya will be discussing about the rehabilitation. So, coming to painful joint, why do we need to have a clinical approach? Painful musculoskeletal condition, they are the leading cause of disabilities globally. They are prevalent across the lifespan. They not only affect small children but also affect elderly, but are significantly associated with increasing age. They not only cause functional limitation, they also cause participation restriction and have a higher economical cost to the patient for living as well as to the hospital. So based on a large-scale study, which was the global burden of musculoskeletal conditions, they suggested, talking about just the rehabilitation, that there were 2.41 billion people roughly who have certain conditions which require rehabilitation. Among those 2.41 billion people, musculoskeletal conditions were the largest contributors, with an estimation of 1.71 billion people who were in need for rehabilitation. If we further divide this 1.71 billion people, lower back pain had the largest number of contribution, causing roughly contributing to 64 million, followed by neck pain, osteoarthritis and rheumatoid arthritis. If we divide just the arthritis, we see that osteoarthritis had the largest number with roughly 528 million. A thing to note here is, although the number is high, but not all patients of osteoarthritis are in need of rehabilitation, or not all patients are symptomatic. So their numbers are usually high. Gout, which is now the most common form of inflammatory arthritis, amounting to 42 million, and rheumatoid arthritis, which is now the most common form of autoimmune systemic inflammatory arthritis, amounting to 18 billion. So to have a comprehensive approach on the joint pain, we need to understand 3 things. Its origin, diagnosing the underlying cause, because it has various sources of causes, and once we know the diagnosis, we need to employ personalized treatment strategies which can help in improving the patient quality of life. So to discuss these 3 points in more further details, I would now like to call Dr. Akshay from orthopedics.
Good morning to all the dignitaries, my colleagues and my juniors. Today I will be discussing the types of joint and classification of the joint diseases. Joint can be classified on the basis of structure. Broadly it is divided into 3 types, that is fibrous, cartilaginous and synovial. Fibrous is subclassified into suture type, which is only found in cranium. Second one is syndesmosis joint, which connects to parallel bone with the ligament or membrane, example tibia fibular syndesmosis, and the third is gomphosis, which is seen in teeth and its socket. The cartilage joint is subclassified into primary and secondary. Primary is found in the growth plates, costal cartilage in it, and the second cartilage joint is found in pubic symphysis. The third and the major type of joint present in the body is the synovial joint. Synovial joint is further subclassified into plane, hinge, pivot, condylar, saddle, and ball and socket type of joint. So this is the anatomy of synovial joint. Synovial joint is a freely movable joint characterized by presence of joint cavity filled with synovial fluid, which prevent friction between the articulating cartilage surface. Synovial fluid is surrounded by the synovial membrane, and outside capsule is present. The hyaline cartilage forms the articulating cartilage covering of synovial joint. Before going in detail of arthritis, we should know the basic difference between arthralgia and arthritis. So arthralgia is a symptom and arthritis is diagnosis. Arthralgia may or may not be inflammatory. If the symptoms occur in 2 or more joints, then it is known as polyarthralgia. Example is bursitis, tendinitis, fibromyalgia, and post-viral sequelae. In arthritis, it is an inflammatory disorder. It is further subdivided into mono, oligo, and poly on the basis of number of joints involved. In mono, there is involvement of only one joint. Example, septic arthritis and tubercular joint. While in oligoarthritis, there is involvement of 2 to 4 joints. Example, osteoarthritis and psoriatic arthritis. In polyarthritis, there is involvement of greater than 4 joints. Example, rheumatoid arthritis and SLE. Sources of joint pain can be due to the structure within the joint or can be outside the joint. So I will be discussing first the structure within the joint, that is known as the intra-articular, which consists of capsule, periosteum, ligaments, subchondral bone, and synovium. Inflammation of synovium is known as synovitis, and inflammation of joint capsule is known as capsulitis. We should note that even though articulate cartilage lies within the joint, but it is not a source of pain due to lack of nerve ending. Structure adjacent or around the joint can cause joint pain, which can be the bursa, tendon, etc. It is usually clinically diagnosed, and the treatment is mostly the ice therapy, which consists of rest, ice pack application, elevation of limb and compression, and analgesic. In the severe cases, we can go for the local debridement. Joint diseases can be classified on the basis of the etiology. First one is infective, which can be caused by acute or chronic. The second is inflammatory arthropathies, which consist of rheumatoid arthritis and spondylopathies. Next is degenerative, which consists of osteoarthritis. It can be associated with the metabolic diseases like gout and pseudo-gout. It can be a neuropathic joint like tabes dorsalis and syringomyelia. Can be due to neoplasm, metastasis, and giant cell tumor. It can be due to trauma, which can be a direct trauma or indirect trauma. And last, it can be due to local joint disturbances, which consist of avascular necrosis and osteochondritis dissecans, which is a pathological lesion affecting articular cartilage and subchondral bone. So these are some common presentation of joint pain by which the patients come into our OPD. So the case 1 is 30-year-old female, came with complaint of pain in multiple joint, more in lower back and both knees since 10 days. In case 2, there is a 49-year-old female, came with complaint of multiple joint pain, stiffness, lethargy, multiple swellings in hands since 2 years. And in case 3, there is a 67-year-old male, came with complaint of pain in bilateral knee, right more than left since 5 years. So we see that the patient may have given a similar history, but how to approach these type of cases clinically, I would like to call Dr. Mohit Dulani for further discussion.
Good morning everyone. I will be presenting how to clinically approach the joint pain, covering its history and examination part. So here is a common scheme where we start with the history. In history we ask chief complaints, history of presenting illness, past, personal and family history, history of allergy or any drug intake, history of and social history. After history, next step is examination, which consists of general, local and systemic examination, which helps us forming a clinical diagnosis. After that, we advise the patient for relevant blood and radiological investigations, which can lead us to the diagnosis and plan the management, which can be pharmacological or non-pharmacological. and after that we can advise the patient for rehab if necessary. So one of the most common complaints associated with joint is pain, which has certain characteristics like site, onset, duration, aggravating and relevant factors, etc., which will be discussed in next slides. Other common chief complaints associated with pain are swelling, wound, discharging sinus, inability or difficulty in moving a joint. So now the different characteristics of pain, starting from duration. If it is less than 6 weeks, it's acute, and if it is more than 6 weeks, it's chronic. The pain can be described in various types like throbbing pain, which is seen in injury, pins and needle and burning sensations, which can be seen in vitamin B12 deficiency and nerve injuries. The severity of pain is described as mild, moderate and severe. There are certain factors that aggravate and relieve the pain. For example, in carpal tunnel syndrome, the pain increases during sleep, and in case of osteoarthritis, the pain increases during the movement. Gathering comprehensive history is essential for identifying underlying cause and plan the management. Starting from past history, we ask the patient for history of any past trauma or surgery, any similar episode in past, and comorbidities. Next is personal history. We ask the patient for their diet, habit, sleep and occupation. In family history, we ask the patient if there is any similar episode in family members. We should also ask the patient for history of any allergy or drug intake by the patient, which can give us an idea. For example, certain medications have deleterious effect, like corticosteroid intake can lead to avascular necrosis of the bone, which can lead to joint pain. And we should also ask for social history, which can give us an idea about socio-economic status of the patient. Having knowledge about distribution of pain to certain joints can give an important clue for identifying certain conditions. For example, involvement of symmetric and asymmetric joints can give us an idea about rheumatoid arthritis and osteoarthritis. Involvement of first metatarsophalangeal joint can give us an idea about gout, and involvement of axial joints can give us an idea about ankylosing spondylitis. So the general physical examination provides overall assessment of the patient's health and identifies systemic signs associated with the conditions. For example, cyanosis can give us an idea about peripheral vascular disease, for example, Burgess disease. Other characteristics we look for are pallor, icterus, clubbing, lymphadenopathy and edema. Now coming to local examination of the joint. Starting from attitude, we should look for the attitude of the limb in which the patient presents to us. In case of lower limb involvement, we should examine the gait. We should also look for footwear and prosthesis wear and tear in relevant cases. Further in inspection, we should look for certain features like wounds, swelling, sinus, skin changes, deformity, asymmetry and wasting. For example, presence of sinus can be an indication of infection, which can give us an idea about osteomyelitis. Presence of deformity, asymmetry or wasting can give us idea about the chronic joint pathologies or trauma. Now in palpation, we examine the patient for local rise in temperature. We should also look for tenderness and swelling for its features like consistency, fluctuation, mobility, transillumination, etc. And we should also examine the crepitus or the click. In range of motion, we should evaluate it both active and passively to assess the restriction caused by stiffness or pain. In active, we ask the patient to move the joint through full range by himself, and in passive, the joint is moved by the examiner. Neurovascular examination is necessary to rule out any neurovascular involvement. And certain joints have certain specific tests which should be performed to evaluate the extent of the joint pathology. Examination of adjacent joints helps us to rule out any referred pain or associated pathology. We should also examine the lymph node to rule out any infected or inflammatory cause. Patients with certain conditions can present to us with limb length discrepancy or atrophy or wasting of the limb. For example, shortening of the limb can be seen in growth plate injury, and lengthening can be seen in cases of trauma or infection. Quadriceps wasting can lead to atrophy in thigh, which is seen in knee osteoarthritis. To measure the atrophy, we measure the circumference of the limb at its maximum girth. Now to discuss systemic examination, extra-articular manifestation and blood investigation, I would like to call Dr. Nirbhay.
Good morning, dignitaries, my seniors and my colleagues. My name is Dr. Nirbhay Reddy. I am medicine resident. I will be talking about systemic examination, extra-articular manifestations and blood investigations in arthritis. So in systemic examination, first we will look for respiratory system. We will look for costovertebral tenderness or any lung crackles, pleural tract, to detect any signs of pleuritis or interstitial lung disease. In cardiovascular system, we will examine for pericardial friction rub or any heart murmur to rule out any valvular involvement or pericarditis. In gastrointestinal system, we will be examining for any organomegaly, abdominal tenderness, to detect any gastrointestinal involvement such as diarrhea or any. In neurological system, we will be examining for reflexes, muscle strength, sensory testing. Also, we will be examining for cognitive function to assess any peripheral neuropathy or entrapment syndrome or any neuropsychiatric involvement. Now coming to extra-articular manifestations. So extra-articular manifestations are symptoms and complications of arthritis which affect the organ and system outside the joints. It can predict the severity of disease and can significantly impact patients' quality of life. Now these are some of types of arthritis which may have extra-articular manifestation. We have divided into primary joint disease coming with systemic manifestation and primary systemic disease which can have joint manifestation. So the mechanism of extra-articular manifestations, there may be chiefly autoimmunity, cytokine mediated inflammation, genetics, also environmental factors also play a role in extra-articular manifestations. In immune system dysregulation, there will be activation of immune system against the body's tissue, which will eventually lead to systemic inflammation, which can damage the organs and tissue outside the joints. In cytokine and chemokine release, there may be involvement of TNF-alpha, IL-6 and IL-1, which promote systemic inflammation affecting both joints and extra-articular sites, which may have extra-articular manifestation. In genetics, there are certain types of gene mutations which may cause extra-articular manifestations, such as HLA-DRB1 in rheumatoid arthritis, interferon regulatory factor 5 in SLE, HLA-B27 associated with ankylosing spondylitis and IBD. In environmental triggers, infection, smoking, diet and air pollution such as silica dust, which may cause interstitial lung disease in RA. These are some common extra-articular manifestations such as valvular heart disease, glomerulonephritis, anemia, as seen in SLE. In gout, we can find renal stone. In psoriatic arthritis, we can find metabolic syndrome, obesity. Also, we will find skin changes, nail changes such as nail pitting and onycholysis. In ankylosing spondylitis, we will find sciatica, neuropathy due to nerve compression or restrictive lung disease due to spinal fusion. So, some common extra-articular manifestations such as scleritis, which is common in RA, uveitis, which can be seen in psoriatic arthritis. There are rheumatic nodules and vasculitis also seen in rheumatoid arthritis. Discoid lupus and butterfly rash can be seen in SLE. These are the changes such as psoriasis and onycholysis seen in psoriatic arthritis. Now coming to blood investigation, we will start from some basic common blood investigations such as CBC to reveal anemia, which is commonly associated with SLE and rheumatoid arthritis. There are inflammatory markers such as ESR and CRP which may be raised. These are some specific blood investigation such as rheumatoid factor and anti-CCP to rule out the rheumatoid arthritis. In autoimmune condition, we can go for anti-nuclear antibodies. In cases of gouts, uric acid levels may be elevated. HLA mutation is also associated with ankylosing spondylitis, inflammatory bowel disease, also in rheumatoid arthritis. We'll also look for calcium phosphorus PTH to rule out secondary hypoparathyroidism, which is commonly seen in lupus nephritis. Now, this is the basic algorithm. This is not an exact way to go, but we can have a basic idea. So, patient coming with joint pain, we will first do basic investigations such as ESR, CRP, CBC, which may be normal or may be raised. So, if it comes normal and along with the radiological findings, then we can consider it as osteoarthritis. If ESR and CRP are raised, but and also there is anemia on CBC, we can go for ANA. If antinuclear antibodies are positive, we can look for RA factor or anti-dsDNA or any other molecular serological markers. In RA factor, if it is positive, we can consider rheumatoid arthritis. If it is negative, we can go for anti-CCP. If it is positive, then we can consider rheumatoid arthritis. If it is negative, then we should consider some other diagnosis. So in anti-dsDNA, if it is come positive, then it is systemic lupus erythematosus. If it is negative, we can look for some other diagnosis such as Sjogren syndrome. If ANA is also negative, then we'll look for involvement, if it is asymmetric involvement or symmetric involvement. If it is asymmetric involvement, along with presence of elevated uric acid, renal stone, and involvement of first metatarsal phalangeal joint, then we can consider it as gout. And if there is skin changes or nail changes as described above, we can consider it as psoriatic arthritis. Now, if it is symmetrical involvement, and we'll look for HLA gene mutation, if it is positive with GI involvement, we can consider it as IBD associated arthritis. And in cases of no GI involvement, we can consider it as ankylosing spondylitis. Now, I would like to call Dr. Akshay Yadav to further discuss about radiological investigation and pharmacological.
Thank you, Dr. Nirbhay. Now moving forward to radiological investigation and pharmacological treatment. So this is the X-ray of a normal joint in which we can see that the joint space is maintained and the articular cartilage surface is smooth with no osteophytes. But as we can see in the later stages of the osteoarthritis, the joint space is reduced and there is presence of osteoarthritis. This is the X-ray of a normal hand and in the patient of osteoarthritis, rheumatoid arthritis, in which we can see that the joint space is reduced with periarticular osteopenia and deformity of the first metacarpophalangeal joint. Now coming to CT, the indication of CT scan is to evaluate arthritis in the axial joint, as we can see in the sacroiliac arthritis, and for assessing intra-articular fracture like in the fracture of the radial head. Evaluating joint in overlying structure obscuring plane radiograph, we need CT scan. The next one is a USG. The indication of USG is to assess the soft tissue including tendon, bursa, ligament, and it is also used for joint aspiration and for injection. The next is MRI. MRI is the best modality for assessing the soft tissue. As we can see, that is a MRI of the knee joint in which we can see that the ACL is intact, but in the cases in which we can see that there is a torn ACL. And the greatest use of MRI is for assessing rotator cuff tear, ligament or meniscal abnormalities of knee and wrist joint. In other investigation, we can have the joint aspiration analysis, which is also known as arthrocentesis. The arthrocentesis is used to diagnose infection, inflammatory diseases and crystal arthropathies, and it is also used for treating the painful effusion of joint. Now coming to pharmacological management, the goal of pharmacological management is to reduce pain, to control the inflammation, for disease modification and to improve the quality of life of the patient. Classes of drugs used in arthritis can be the non-steroidal anti-inflammatory drugs, the disease-modifying anti-rheumatic drugs, and corticosteroids. The non-steroidal anti-inflammatory drugs inhibits the cyclooxygenase enzyme. It can be a selective COX-2 inhibitor like etocoxib, can be a preferential COX-2 inhibitor, the non-selective COX inhibitors, and the analgesic antibiotic with poor inflammatory action like paracetamol. DMARDs is the purpose of using DMARDs is to slow or stop the progression of inflammatory arthritis, particularly rheumatoid arthritis. The DMARDs can be a non-biologics or biologics. In non-biologics, the first one is methotrexate, which is the first line of drug for rheumatoid arthritis. Its adverse effect is the liver effects and the teratogenic. And in the cases where methotrexate is not tolerable, we can go for leflunomide, which inhibit pyrimidine synthesis, and the adverse effects are same like liver effects and teratogenic. In biological DMARDs, the purpose is to target the specific molecules involved in the immune responses. It blocks the cytokines and the immune system components that drive inflammation. For example, in the case of rituximab, it inhibits the anti-CD20 and eliminates the B cell. In tocilizumab, we can see that it blocks the IL-6 receptor. Corticosteroids is a potent anti-inflammatory agent used to manage acute flares of arthritis. Common corticosteroids which we use is prednisone and methylprednisolone. The mechanism is to suppress the immune response and to reduce inflammation. Dose and duration should be guided by severity of the exacerbation of the episode. In the chronic dose is 5 to 10 mg. In the cases when we start the DMARD, we should start with corticosteroids. And in the cases where DMARD is not acting, we can also use corticosteroids. The side effect of corticosteroids is osteoporosis and avascular necrosis. Now for non-pharmacological treatment, I would like to call Dr. Mohit Dhilwani.
Thank you, Dr. Akshay. Now I'll be covering the non-pharmacological management. Starting from injectable therapies. For example, we use hyaluronic acid in conditions like mild to moderate osteoarthritis. It acts by providing lubrication and cushioning within the joint. It is not given in cases of active inflammation or allergies. Next is platelet-rich plasma. It is used in mild to moderate osteoarthritis, chronic tendinopathies, and ligament injuries. It acts by promoting the growth factors which causes tissue repair and reduces the inflammation. It is not given in active inflammation and platelet disorders. And next is stem cell therapy. It is used in significant cartilage loss and avascular necrosis of the bone. It acts by regenerating the damaged tissue by differentiating into the necessary cell types. It is avoided in malignancies. These therapies can be given alone or in combinations. In surgical management, first is arthroscopy, which is diagnostic and therapeutic. In therapeutic, we use it in cases of infection and synovitis. We use it for debridement and synovectomy. In cases of loose body formations, which can be little bone fragments or osteophytes or any foreign bodies, we use it for loose body removal. In cases of soft tissue injuries, like here we can see in this first picture, there are torn fibers of ACL, and in second picture, it is reconstructed using fiber tape. It is shown in the picture. In cases of trauma, we can go for open or closed reduction, internal fixation with K-wire fixation, screw fixation or plating. Now certain surgical modalities for osteoarthritis. First is osteotomy. It is done in early to moderate osteoarthritis. In this, we correct the mechanical axis, thereby improving the load distribution. Next is hemiarthroplasty, which is partial joint replacement. It is done in degeneration of any one articulating surface of the joint or trauma. In it, we replace the damaged partial joint with the prosthesis seen in the image. Next is total joint replacement. It is done in moderate to severe cases of arthritis, trauma or avascular necrosis. In it, we replace both the articulating surface which forms the joint, hence eliminating the pain. And the final is arthrodesis. It is done in severe cases of arthritis where the total replacement is not feasible. Other indications are trauma and avascular necrosis. It is surgical fusion of the multiple joints hence abolishes the movement and at the painful joint, thereby preventing the pain. Now for the rehabilitation management, I would like to call Dr. Rukayyari.
Thank you, Dr. Mohit. A very good morning to respected dignitaries, teachers, seniors and my dear colleagues. I am Dr. Rukayyari, second year junior resident from the Department of Physical Medicine and Rehabilitation. I'll be discussing about physical medicine and rehabilitation management of painful joints. As rehabilitation is not used in the pre-operative conditions, it's also used in the post-operative conditions. So our main goal for the acute condition, first we have to immobilize the joint, then relieve the pain and inflammation by giving appropriate medications and intra-articular injection later on. We have to increase and maintain the functional performance of the patient. For deformities and contractures, we have to give the proper joint alignment and give aids, assistive devices to prevent the joint contractures. And increase and maintain mobility, strength and endurance, and facilitate successful adaptations for that is like we'll give cable bars for the patient who are not able to walk on the stairs. And for the osteoarthritis knee conditions, we'll give English toilet for defecations and urination, and by this we can maintain the self-efficacy of the patient. Rehabilitation of painful joints, our main aim is to educate the patient and also to the family member, as degenerative arthritis is a progressive in nature, so we have to educate the patient and the family to take early interventions as soon as possible, and to reduce the joint pain and inflammation. Apart from this, in rheumatoid arthritis, we have to prevent joint and soft tissue contracture, improve and maintain of the functional maintenance of the functional mobility, and minimize the joint load through assistive devices. For osteoarthritis, we have to do lifestyle modification in the form of dietary and activity modification, weight reduction in overweight patients, as overweight is the risk factor of the obesity, and biomechanical correction, which I will be discussing in later slides. These are various splints or orthotics which are useful in rheumatoid arthritis. First one is the Botanier splint, which is used in Botanier deformity. This is the resting hand splint, which will give to immobilize the wrist and to prevent further deformity. And this is the ankle foot orthosis, which we are using to immobilize the ankle and to prevent further deformities, like in the form of later there can be foot drop or any problem in any joint of foot or ankle. So biomechanical correction, bio means body and mechanics means movement. Our body is aligned and joints are also aligned, so we have to align our joints properly so that any joint disload or misalignment will not happen and it will affect our joints. So first we'll do joint alignment and proper and position posture in the form of proper posture and postural correction as shown in the image. This is our gait lab where we do postural correction of the patient. Then load distribution, as you can see in the image, when we walk properly, our ground reaction force is parallel to our body, and if we will flex slightly, it gets anterior and gets load to the axis joint of the body, that is the spine. Then kinetic chain optimization and gait analysis, and we have to solve the aerial difficulties which the patient faces. So this is the example of the biomechanical correction of the osteoarthritis knee, bilateral osteoarthritis knee, grade 2. We can see in the first two images that there is a varus deformity of the knee. After that, we did the walking assessment of the patient. As we can see, the patient is walking she's limping, that is the antalgic gait. After walking assessment, we plotted the graph in our gait lab, and we find that quadriceps wasting is there, due to which the patient is not able to walk. So we advise the patient for X-ray bilateral knee AP standing and lateral. We can see that there is reduced joint space and mild varus deformity present. So we advise the patient with the lateral foot or in outsoles in the footwear, as you can see in the images. This is done so that the middle compartment, which is getting collapsed due to the ONE, the weight will be shifted laterally and equally distributed so that the middle joint will not collapse further. And after 3 to 4 weeks, we can see that the patient is able to walk without limping. We also have superficial and deep heat modalities for painful arthritis, which are as follows, like hot and cold therapy, wax bath, deep heat in the form of ultrasound therapy, transcutaneous electrical nerve stimulation, intrapharyngeal therapy, neuromuscular electrical stimulation, and extracorporeal shockwave therapy. We also do post-surgical rehab. Our main goal is to return the patients to their pre-operative level of function. So early post-operative rehab, which is for 1 to 2 weeks, we reduce the pain and do the weight bearing of the patient and strengthening. In my mid-phase rehab, that is 3 to 6 weeks, we do strengthening, functional training, and also swelling management. In late phase rehab, that is 6 to 12 months, we do strengthening, advanced functional training, and gait training of the patient. And in late long-term rehab, that is 3 to 12 months, we work with strengthening and endurance, and for sports patient, sports-specific training, and return the patient to his activity of daily living. We also have advanced robotics in painful joints which are being used, that is robotic rehabilitation devices, robotic exoskeleton, robotic joint manipulation, target pain management. Their role is to avoid the improper joint patterns, thereby controlling the proper joint movements, and they provide the sensory feedback, safe environment, and weight support. Now I will like to call Dr. Karthik for case discussion.
And now that we have a better understanding of how to approach the joint pain, we come back to the cases we have discussed previously. So there was a 30-year-old female patient who came with a chief complaint of multiple pain, more in lower back and both knees, and since 10 days. Now after a detailed history and examination, we further got to know that the pain was gradual, aggravated by activity, and relieved by medicines. She also gave a history of 2 weeks fever 2 weeks back, which lasted for 1 week. There was no significant past, personal, or family history. On examination, we could note there was diffuse tenderness around her knee and her lower back, and her range of motion, though within normal range, was terminally painful. So I would like to ask, at this point, what would you like to do? Anyone from the audience?
We will advise for CBC, SRCR, and we will exclude the OA just because of the patient age and giving the history of the 2 weeks earlier fever.
But patient is only 30-year-old. Why would you like to rule out OA? Why not other causes?
Other causes will be rheumatoid arthritis or...
For that, what would you like to do?
RF factor and anti-CCP.
Okay. So this was the result. We got the CBC done, which was within normal range. LFT-RFT was within normal range. Our inflammatory markers were slightly raised. The serological markers were negative, and vitamin D was also checked, which is a common cause of joint pain in this age, was incidentally found to be normal. So we went ahead with the radiological investigation as well. The lower back was roughly normal, and you could see maybe some changes in the joint, but nothing suggestive of osteoarthritis. So what would you like to suggest as diagnosis? Any other significant part of history? So she also gave us a history of fever, which was 2 weeks back and lasted for 1 week. Ruling out everything else, we came to the diagnosis of post-viral arthralgia. Okay, for this, short course of analgesics was given as treatment, and because we found out that vitamin D was also lacking, so we have to give a supplement of cholecalciferol with vitamin D for at least 2 months. Coming to the next case, there was a 49-year-old female who came with a chief complaint of pain in multiple joints, stiffness, lethargy, multiple swellings, deformity in hands since 2 years. On examination, the pain was gradual. There was more in the morning with stiffness, varied by activities and pain and medicines. There was also a history of similar complaint in mother, and there was no significant past or personal history. So looking at this history, what would you like to advise?
And RF factor and anti-CCP.
Okay, so you don't want to rule out rheumatoid arthritis. Okay, so we went ahead with the investigation, and we did find out that her inflammatory markers were raised, ESR 54, CRP 87, and yes, the RA factor anti-CFP did come out positive, although her ANA profile was negative. So we conclude the diagnosis was rheumatoid arthritis, and she was started on treatment as discussed previously. First on NSAIDs, then immunosuppressive therapy was given with corticosteroids and DMRDs. And to prevent further deformities, we also provide supportive devices, center for adequate rehabilitation. And if all this conservative management does not work on the later stages, we can also advise for synovectomy if the stage is still on synovitis. And once the joints are completely degraded, we can go for arthroplasty. So now the third case, which is a 67-year-old male patient who came with the chief complaint of bilateral knee, left more than right since 5 years. On further examination, his pain was gradual in onset, aggravated on walking, climbing stairs, and relieved by rest and medication. He was also a known case of hypertension since 10 years, and there was no significant personal or family history. On examination, there was swelling and varus deformity in both her knees with slight fixed flexion deformity. There was crepitus in both the knees during movement, and the range of movement was painful flexion terminally and with restriction of extension. So at this point, what would you like to do and rule out? Okay, yes. So the pain of osteoarthritis does increase during movement. So we went ahead with the investigation. His hemoglobin was slightly lower, 8.9. Inflammatory markers, though slightly raised, but can be seen in osteoarthritis as well. And vitamin D in his case was also found to be reduced. But the X-ray was suggestive of severe arthritis. We can call it grade 4. So treatment in this case is usually total knee arthroplasty. But before we go ahead with the surgery, we do give a trial of lifestyle modification, weight reduction, rehabilitation, adequate physiotherapy, and analgesics. And only when they do not work adequately, patient still complains of continuous pain, we go ahead with total knee replacement. So, after discussing all these cases, we can have a simple algorithm which can help us with certain diagnosis. So, a patient coming to OPD with musculoskeletal complaint, we go ahead with the history and examination. We try to find out whether the pain is originating from articular surfaces or non-articular surfaces. If the pain is of non-articular origin, we should consider diagnosis such as fibromyalgia, polymyalgia rheumatica, bursitis, tendinitis, or any myopathy or myositis. If the pain is of origin from the articular surface, we should find out whether the pain is of acute origin or chronic origin. If they are acute, it can be an acute arthritis such as acute flare of an osteoarthritis. It can be a cause of septic arthritis, gout, pseudogout, or reactive arthritis. If it is chronic, we should look for if the cause is from inflammatory cause or non-inflammatory. If it is non-inflammatory, it could be osteoarthritis, osteonecrosis, or hemochromatosis. Further, if the cause is of inflammatory origin, we should look for the number of joints involved. If only 1 to 3 joints are involved, that is mono or oligoarthritis, we should consider the diagnosis from TB joint or psoriatic arthritis or reactive arthritis. If more than 3 joints are involved, we should look for whether the involvement is symmetric or asymmetric. If it is having asymmetric involvement, we should consider diagnosis of reactive arthritis, psoriatic arthritis, enteropathic arthritis. If it is a symmetric involvement, we should look for involvement of small joints such as of those of hand and foot. If the hand and foot joints are also involved, we can consider diagnosis of rheumatoid arthritis. If they are not involved, we can consider diagnosis from ASLE, poliomyositis, or scleroderma. Of course, all these diagnoses have to be collaborated with the relevant investigation as discussed previously. So in the end, I would like to say that joint pain is a widespread issue. It ranges from age-related wear and tear to autoimmune disorders or to mild to severe injuries. Given its diverse origin, a comprehensive understanding of the underlying cause is required, as well as personalized treatment strategies are needed for adequate rehabilitation. So an early diagnosis, a combination of therapies, and a commitment to joint care is definitely required to improve the overall function and quality of life for the patient. Thank you.